Good afternoon, everyone. Thank you for being here today. My name is Pooja Alawalia, and I am pleased to welcome you to this 25th anniversary series of webinars. I would like to respectfully acknowledge that the Realize office and where I live sits on the traditional territory of the Wendat, the Anishinaabeg, the Haudenosaunee, the Métis, and the Mississaugas of the Credit First Nation. I give thanks to the people who have cared for this land over generations and acknowledge the gift and privilege that I have to live and work here. So thank you again for attending this webinar. This webinar is part of the Realize 25th Anniversary webinar series. In 1998, a group of people across sectors of health, policy, and research, and most importantly, lived experience of HIV, met in Quebec City to talk about how rehabilitation could play a role in quality of life for people living with HIV. There were a lot of unknowns then about HIV, about the role that rehabilitation could play, and where the conversation would lead. Our founding director, Elise Zach, said people began to recognize that there was an increasing role for rehabilitation to help support and improve people's physical, psychological, and social health and participation. People working and living with HIV didn't understand what rehab is or could do, and people working in rehab didn't know much about HIV. From that meeting, the Canadian Working Group on HIV and Rehabilitation, now Realize, resulted. Over the years, we have shifted our focus from pure HIV and rehabilitation to optimal health and well-being, as the needs of the community of people living with HIV have changed. It is this flexibility, ability to transform and grow, and bridge gaps across sectors that I feel really exemplifies Realize. As I've mentioned before, my name is Pooja Alawalia, and I'm the national lead for optimal health and well-being. I've been with Realize for 8 years, starting when it was Quigger and being part of the transformation to Realize and of HIV and rehabilitation to optimal health and well-being. It's my pleasure to be facilitating this webinar today. I'd like to introduce our two panelists, Leanne Dolan and Bob Leahy. Leanne holds a degree in social work from the University of Calgary. Her interest in HIV began when working with an interprofessional health team providing medical and social supports for people using illicit drugs intravenously. Leanne went on to contribute to local, provincial, and national and international program development with AIDS Calgary. She was also part of the Alberta Community Council on HIV from 2002 to 2006 in the roles of co-chair, International Action Committee, and co-chair Advocacy Committee. From 2005 to 2010, Leanne was on the board of directors of the Canadian HIV/AIDS Legal Network, serving as president from the board from 2007 to 2010. In late 2006, she moved to Toronto to work with the AIDS Committee of Toronto as the Director of Programs and Services, and in 2010, Leanne joined the Canadian Working Group on HIV and Rehabilitation as Program Director. It was during her tenure at Quigger, under the guidance of Elise Zach, that she began to understand and work in the area of HIV and rehabilitation. Leanne was privileged to contribute to many facets of Quigger's work, including the development of the electronic guide on HIV and rehabilitation, commonly known as the E-module. Leanne currently lives on the West Coast and is working to provide treatment opportunities for those incarcerated or street involved and engaged in substance use. Bob Leahy was diagnosed with HIV in 1993 and has been an extremely prominent activist ever since. He has served on the boards of PARN, the OHTN, and the CAS, and was the editor, then publisher of PositiveLight.com, Canada's award-winning online HIV magazine. He is most proud for being the early leader of the U=U campaign in Canada. Bob has also received awards from the OAN Honor Roll, the Casey House Award, Pause Magazine, and the Queen Elizabeth II Diamond Jubilee Medal. Now mostly retired, he lives contentedly in the small town of Warkworth, Ontario. Thank you for both of you for being here. So, Leanne, can you tell me what your introduction was to Realize or Quigger, and how did you become involved with us as an organization?
Thank you, Pooja, and thank you to Realize for inviting me to be on the panel today. I'd like to acknowledge the people of the Songhe and Esquimalt nations and the Coast Salish territory that the gracious hospitality while I present this webinar with you, all you folks. I really was honored and am humbled to be here today. As mentioned, I began working with just want to start by saying I'm living with a disability that impacts my memory. And so I've made notes, and Pooja, and speaking with you and Janet, you encouraged me to do that, and that was okay. So if I'm looking down, that's what I'm doing. So as mentioned, I began working with Van Quigger team in 2010. At that time, I believe it included myself and maybe 4 other staff. There might have been 4 of us in total, and a few consultants that came on after. The other part of it was that I quickly realized that there was a whole multitudes of people and expertise behind the work that Quigger was doing in the form of volunteers and partnerships. We at that time had a board of directors that was pivotal in the work that we were doing, and kind of hands-on work, and we were such a small team. So when I chose Quigger, I'd been involved, as you had mentioned, with HIV and AIDS for about 10 years at the local, provincial, and national level, and a little bit at the international level. But one of the things that I recognized was I didn't know a lot about disability and episodic disability and HIV, and at that time I realized quickly that there was a lot of people didn't know about it in that context, and that was just emerging. From day one, I was mentored by Elise Zach, and I spent a lot of time, all day with her, and she helped me with that, with the onboarding of it. I did learn that the driving force made up of the network of people dedicated to episodic disability and rehabilitation, that something very big was happening. And when I look back, I was only with Quigger for about 3 years, and so again, I'm humbled to be here, and was shocked. I actually had to go back a few times and just like, was it only 3 years? Because we did so much work during that time, and of course, the work has carried on and developed from there. But that invitation of Elise to apply to fill a new program or new position that had started with Quigger, that was the director of programs, and she invited me to apply, and I was a successful candidate. So that's kind of how I entered into the field with the team there at Quigger.
Thanks, Leanne.
Yeah.
It's kind of interesting to see how Realize has grown from such a small organization of 4 people to, I think we're close to 20 people now. So lots of changes over the last 25 years. Bob, how about you? What was your introduction to Realize, and how did you become involved with us as an organization?
Good question. Can you hear me, first of all? Good.
Yes, we can.
Yeah, well, it was certainly, I was just looking through my old notes, and it was certainly pre-2016 when Realize was still called Quigger, and I always had a challenge with that acronym. I could neither pronounce it properly, although I did learn that. How do you say CWGH? What's the last letter now? R. It's almost unpronounceable, right? So I was very pleased to see the name changed in 2016. I remember being at that event with Tammy, and it was a glorious day for Realize, I think, a recognition that things were changing, that Realize needed to adapt. And I think that became a central, the need for change became a central theme of my work with Realize, because as a person living with HIV, I'm very conscious of the fact how much the disease has changed, how much we, as people living with HIV, have adapted and changed considerably. I was diagnosed in '93, so I was pre-treatment. So from looking at that situation then, when we were talking about just keeping alive, and sometimes we had to verge into end of life discussions or palliative care, that kind of stuff, and that seems a long way away. So the disease changed, we changed, and I think some organizations took it upon themselves to change also. Not every organization, I think, has made quite such a dramatic shift as Realize, and I've always felt that if you're not changing to adapt to the kind of things I'm talking about, those changes in people, in the illness, you really have a danger of being irrelevant. The disease moves on and you don't if you're that kind of organization. So I'm very happy to see Realize being one of the organizations which has not just changed its name, but it's changed its focus, and that's good. Throughout my involvement, I have to say it's mostly been about lived experience, because I think that's so important that, particularly when we're talking about aging and issues like that, we do have to hear from the people who are actually experiencing that. The theoretical look at aging, in my view, only goes so far. If you haven't aged with HIV, or if you haven't aged, period, I would stick my neck out and say you don't really know what it's like unless you've been there, and I've certainly been there, because I'm now in my mid to getting on to late 70s. I'm 76, and I'm really finding that as a person, my body is changing. Potentially, my needs are changing. So I'm a different person, and I would hope that the organizations that serve people like myself are also changing. So how did I get involved? I went to National Forum. I remember that was around 2016 too, and I started talking with Kate off and on. She was a sympathetic voice to my concerns about aging. I enjoyed working with Kate, and then gradually became a little bit more involved, until I got to know Tammy. We bonded. Funny story, really. Probably haven't got time for it, but you may have heard it. We bonded over being chased by elephants. Now, how's that for if anybody needs to know that story, I'd be happy to digress. But anyway, Tammy will know exactly what I'm talking about. We were chased by elephants. So after that, I mean, it could only get better than that. I joined, became a co-chair with Tammy on a project which initially started to look at the clinical aspect of living with HIV, and we soon realized that wasn't really where the need was. We needed to look at health and wellness issues, and so that's where I think we're going to talk a little bit about that later. But that's how I kind of got to that point, through a combination of lived experience and knowing my way around the sector a little bit, and so I was very happy to settle into a position, or a volunteer position, with Realize, which utilized my lived experience and hopefully my very opinionated take on living with HIV and what was required by people like myself. So that's where we are. That's where I got to where I am now. Now I'm mostly retired, but I do dabble. I'm a dabbler now, and I like that. If word of advice: if you retire, don't retire entirely. Try dabbling. It keeps your mind active, and I'm kind of enjoying it.
Thanks, Bob. We appreciate the fact that you still dabble in the work world. It makes our lives exciting and fun, and we enjoy working with you. I appreciated the fact also that you really highlighted the fact that the importance of the lived experience and that we can't do this work without that lived experience, and at the same time being adaptable. And I like to think that Realize tries really hard to have those two sort of features at heart when we do our work. Because if we weren't able to change, we wouldn't still be here. So Leanne, I'm going to focus on you a little bit now. Um, so as we described earlier, the real initial focus of Realize then Quigger was HIV and rehabilitation. Um, what did you learn about that? And because you mentioned you spent a lot of time with Elise, Zach, learning about that. And why did you feel that it was an important message then?
Yeah, I guess I you know I one of the things that and thank you, Bob, for sharing what you did, because one of the things that it twigged my memory just around the attraction to Quigger, and I'll probably call you Quigger throughout the time. I'll try and shift over when I can, but was that that all of the work, everything that the team there was doing was based in lived experience of people for people, and the conversation around looking at or recognizing HIV as an episodic disability and what that meant, and those frameworks that were being developed, and those pieces. It kind of was grounded for in my recollection of it around something that a piece of work that was developed. It was called Module 7, and it was developed out of the Wellesley Institution at the time, and Quigger was involved in that, but with some people that were doing a little bit of clinicians, but people that were living with HIV were part of that, and were really the driving force of it. And I think that that development of the Module 7 was kind of the start of a piece of work that we were able to take and develop from there. The internet and interprofessional learning kind of course that was developed went into the universities, but it was all driven by these case studies that had been developed from there, and were kind of tweaked as we went through. And I appreciated Annette and Kelly and Janet in helping me remember some of that work, because that work was key. Those case studies were key, and those case studies were all developed by some clinicians for sure, but they were driven by the lived experience of people that were living with HIV. There was no cases, there was no information, there was no grounded in the reality of what was happening every day, and how things were changing, and there was this kind of idea that when HART came along, the medications came along, that was it, we were done, kind of from the broader kind of people could now live. It wasn't people, we weren't experiencing the level of loss that we were experiencing previous to that. But the side effects of those early medications, and that was kind of when I entered into working in HIV, were devastating. People were not able to participate in a way that you wanted to participate in life. So it was those early kind of pioneers in that, and I often look at them as the ancestors of the work that we did, and some of those people are still here and some of them aren't. And that was the reality of it for the work that we were doing. And so that Module 7 was a key component of the work that Quigger ended up doing. And actually Quigger sought and gained permission from the Wellesley Institute to take that module and develop it further, which ended up being the interprofessional learning course that was done, and then became the morphed into the E module. But those are, and to be clear, the Wellesley Institution was more than happy to see that work taken and developed on. And I don't know the institution now. I mean, I live on the West Coast now. I'm doing different work, but I know that the people that were working there and the work that was being doing there at that time was quite remarkable. And so, you know, I think it's really important, that is really important. And when I came out to Quigger, so then the conversation was, okay, what do we do with this? How do we move it forward? You know, we had a situation at that time where people living with it were living longer with HIV and needing rehabilitation services, and even the, you know, even the discussion around calling it rehabilitation services. Sorry, I'm just gonna turn that off. Even the discussion around calling it rehabilitation services was hard to swallow at that time. You know, it really was a difficult time for everyone. But, you know, so people were living longer and requiring those services, and we had few people, the rehabilitation professionals, working in HIV care in Canada. It was just emerging at that time. And so some of those pioneers in the universities, like, you know, the Kelly O'Briens, the Patty Solomons, the, you know, and I'm not going to, you know, I'm trying not to name names because I don't want to miss people. But, you know, out of the U of T, out of University of Manitoba, Dalhousie, you know, Nancy, some of those folks, they were driving that, and they were driving it hard in those universities, and calling mostly for the work to be done interdisciplinary. In an interdisciplinary fashion, because it was so complex what the reality of what was happening for people living with HIV, that trying to provide services just one person was unrealistic. And then the person living with HIV had to tell their story over and over again to different folks and different service providers. And so it became so complex that the interdisciplinary kind of structure of working with folks and providing services was very important at that time. And so that was emerging, and that was work that Quigger got to do. I mean, we were privileged to be doing that work at that time. Did you want me to talk about the e-module or come back to that? Or
You know what? Our next question's on the e-module. So the e-module, you sort of touched on it a little bit, that the module 7 was the basis of major work, which ended up being the e-module. It's now called the e-module in HIV and Rehab Resource, but it was developed in 2011 and has been updated a fair number of times since then. And you were sort of right there in the early parts of it. So what was that process like? And why was and is it still such an important document in your mind?
Right, thank you. Yeah, thanks for that question. The you know, I kind of, and I was trying to remember kind of the process and how that went, and that's where I leaned heavily on Annette and Kelly and Janet when I was preparing for this. It happened in my mind quickly, and there was a lot of people involved, because what happened was, you know, we had kind of developed that course, and that was getting out into the universities, and we were talking to a lot of people around that, and in fact, in those early days, we were there was some money coming in from the universities that were using that course to Quigger, that was helping us finance some of that early work with the e-module. And we, you know, I know Annette was brought on as a consultant kind of to help us pull it all together, and Janet was there, and Kathy, and I don't know if Kathy is still with Realize, but she was doing the IT, kind of the behind the hyperlinks and that work, because, you know, when the e-module was, it kept growing. It got bigger and bigger and bigger, and we ended up with 7 modules within it. But oh, good, she is still with the organization, Kathy. I see Janet's mentioning, but but the early days of it, and I was talking to Kelly about this. I swore that the Quigger's kind of version of around the kitchen table was Elise would go away on the weekend, and she would, everybody was connected at that time, and I swear they had dinner parties, and then they would all, and then she would come back on a Monday with new ideas and new pieces to add to it, and so we were all working flat out, but and always with the guidance of people who were living with HIV, and they were forefront of everything that we were doing, and really relying on that work. But one of the things that I think provided some credibility and allowed us to get some of that early kind of funding. So anybody who's ever worked at Quigger, and I'm sure realize now, is an expert on writing funding proposals. So we became very good at it because we were piecemealing. We would get a funding proposal of 100,000, or less, or a little bit more, but it was the evaluation that kind of went along with it. So it started with the research and then the evaluation, and those early days of kind of sending it out to a group of people that were working in the field, and were also and people living with HIV, and they were emails. Like, so just to give context to the time that we were doing that, the electronic kind of module was emails. So we were sending them out every 2 weeks or a month or so. In between, we would send out a module, and then there would be a whole discussion, and people would practice on it, and they would send it, give us feedback about things like the terminology, the formatting and layout, the hyperlinks, the frequency of the case studies, the relevance of the case studies. So we were able to tweak those and work with those, but it really was evidence informed. We even though it happened quickly, a lot of work went into ensuring that we had something that would be useful for people. So I think we launched it in 2011, and correct me if I'm wrong on that, but and launch we with the help of Kathy at the time, and people who were working at Quigger, and our partners, we developed the Quigger campus, and I went on and noticed that that's still there. So I went on to the email, and so we were able to have it there, but it went out widely, and we had already started the momentum on it even before the launch, and so that was helpful to kind of get it to the right people and move it forward. Yeah.
Thank you. It sounds like a really evidence-based iterative process, which is great. And even now, for all the updates, we share it with people with lived experience. We share it with clinicians to get their feedback and try and update all the research and see that it's still relevant. And as we always say, it's still one of our most accessed resources on the Realize website, which is exciting.
Fantastic.
So we're gonna move on a little bit from HIV and rehab towards optimal health and well-being, and bring Bob into the conversation. So Bob, you mentioned that you first started connecting with Tammy because of being chased by elephants, and started working with her. And then with me, as an organization, we're making the shift towards optimal health and well-being. What was your personal journey to coming to that message of optimal health and well-being, and why did you feel that Realize was a good place to sort of work on that and promote that message?
Well, I think, Pooja, my focus for the work I've done in the last decade, maybe, there's been a lot about aging, but not so much the kind of conversations that we were having, which was sort of about Aging was usually about the concerns of middle-aged people. This was my perspective, anyway. The concerns of middle-aged people, people living with HIV, who were concerned about getting older, and the deterioration that they were concerned about in cognitive ability, physical ability. That seemed to be where the focus was, and that was sometimes reinforced by I'd hear panels talking about HIV and aging, and I think they still exist, where we have a panel of 40-year-olds and 50-year-olds, which is good. I mean, we need to hear from that population, but I felt that the health and wellness issues of people older than that, maybe this is somewhat of a selfish view because I'm older than 40 or 50, I wasn't hearing many people, many spokespeople for that particular demographic. So I came into that work very much thinking about how health and wellness should play out in that group. And of course, I've tried to have my focus wider than that, but we all tend to, stick with issues which we are familiar with. In fact, that's really why people living with HIV are there, not to theorize, but to share how they're experiencing life with HIV. So when Tammy's project, or the project we're talking about, health and wellness and well-being, started off I think before I actually got into it with largely a clinical focus, actually, and to be honest, clinical issues are not really my thing, to be very personal. I've never really taken so much of an interest in clinical issues as a more patient-centered view of living with HIV, not a clinician's, not a nurse's. And I'm not putting any of those professions down, but this is where I come from, how HIV affects us as people. So as we talked and we looked over documents and saw what the clinical people were saying, this was also about the time too that we were heavily influenced, or the whole sector was influenced by things like 1990, which was a UNAIDS suggestion that we had targets to meet by 2020, and they included things like engagement in care, putting people on medication, testing, of course, and finally, undetectable viral load. And those are all translated into numbers. Those are the 90s we're talking about. And those are good. I mean, I'm not running down that 1990. I happen to like accountability. I happen to like that we have targets. So in that respect, 1990 was useful. It was focused. However, I think I wasn't alone in thinking that sort of numbers-focused work was not the only game in town. In fact, maybe it was the wrong game in town. That maybe we need to look at other additions to just looking at how people were doing from a numbers point of view. And I think the realization came from us and also elsewhere. The Europeans were doing this work, that we needed to expand the 1990 formula to include maybe a fourth 90, which related to health and wellness, how people were doing, and even how stigma was playing a part, all things which were important. But the 1990 approach to HIV did not really cut it. I mean, it was pretty ingrained. I mean, I remember before all this started, I was also working with the OHGN on an anti-smoking or smoking cessation project. with Sean Rourke, co-chaired that one too. It's interesting that the AIDS Bureau, who pretty well control financing, didn't want us to finance that because it wasn't about the treatment cascade or the engagement cascade, which essentially 1990. There was a real focus on funding at that time on only getting people tested, on treatment, and virally suppressed. And I think in retrospect, that is not the only game in town we should be looking at. We need to ensure that people not only are virally suppressed, but they're living the best life possible, given their condition, given their social environments, given their mental health. So the factors which we did not really go into too much, not in my lifetime with the project anyway. I should mention I retired halfway through the project. I actually had open heart surgery, and so that made it difficult for me to continue in the way I'd started off. So anyway, so I mean, the things we started thinking about is the role of nutrition, exercise, diet, and mental health, and social networks and support networks, all the things which have no place in 1990, but which a fourth 90, it was suggested, might remedy some of that. At least we'd have a wider focus. So that's really how it came about, and I think too that my own situation kind of helped me understand a little bit more about health and wellness, and hopefully the fact that I was having heart surgery, the fact that all of a sudden I wasn't talking about comorbidities as you know, we've been talking about comorbidities, you know, illnesses that are in addition to HIV. It's almost inevitable that we're experiencing comorbidities. And so I mean, in my case, I mean, I all of a sudden I was coping with quite a bit. I was coping not just with a heart condition. I had diabetes, I had neuropathy, I had good mental health. Anyway, diabetes, neuropathy, and heart condition was not really what those 40 and 50-year-olds were talking about. So hopefully I brought some of that experience of actually living with HIV, not just aging, but as an older person. And I just kind of a sidelight here. I think we need to continue, and I've Tammy has listened to this too, and Kate has listened to this too. It is because we are all getting older, the population of HIV. I mean, about 50% of us are over 55, and I don't know what percentage are over, say, 70, but I think we need to look at how at the needs of folks who are not just aging, but are aged or older. I'm not sure what is the best word. I don't like either of those. I don't like to be thought of aged. That's not a good word. Old, I suppose. I'm still looking for a more kind way of describing us old folks. But I think that's the next big frontier. I think as the population gets older and eventually old, it opens up a whole new range of issues that define health and well-being, and how we as a sector cope with that. Or in fact, do we cope with it? I don't think we've actually grappled with the fact, you know, who does a 75-year-old turn to when they're not doing so well? Increasingly, that is not necessarily an AIDS service organization. Increasingly, that those are not social They are other agencies. So the role of the sector in aging, I think, is one of the things that first of all we need to assess the needs, and I think some work has been done with that. Kate will be very familiar with that. But then how do we address those needs? So that's sort of an overview of the health and wellness sector, if you like, and my involvement in it. And you'll note that like everything we've been talking about today, it's about change in the person, and the change in their needs, and the change in how the HIV sector responds. And I think we're still work to be done there. We're still grappling with those issues, but we need to get into them soon, because, as I say, the population is growing older in front of our eyes, and we really have to recognize that.
Thank you, Bob. You've shared a lot of information in that. But I like how you keep coming back to change, and changing with the needs of the population and just of the HIV sector in general is important. In our conversation before this webinar, you mentioned that retirement has shifted your understanding and experience of health and well-being. Would you like to share what you've learned so far during retirement?
Sure. I think, I think that this sort of conversation is actually very useful, because if you look at who is talking, what activists, who's left in the activism role now? Because as we get older, we tend to disappear. We tend to become we perhaps we're enjoying retirement, but perhaps also we're dealing with other issues like mobility, or there's a whole host of things that descend on you when you're old, from mobility to hearing to eyesight. This is quite apart from the comorbidity bundle that I was talking about earlier. So you're potentially dealing with quite a lot of health issues, almost certainly. You, at the same time, you sort of want to enjoy your retirement, potentially. So there is, and you potentially, in my case anyway, maybe you still want to be listened to. Maybe you still want to hear your voice. Maybe you're not I'm not really a customer of my AIDS service organization anymore. Because honestly, I don't think I need them anymore. But that doesn't mean that I don't need help in a number of different ways. So I think in my particular case, I think it's been kind of astonishing how I went from somebody who's pretty healthy and had even in my 70s or 60s anyway, I was very active. I was essentially running Positive Light. I was the positivelight.com as the publication that I was very associated with, and I was a writer for them. I was an then I became the editor, then I became the publisher. So I was very active into my 60s, and I was fine with that, actually. I was able to handle it. But as you get older, it's inevitable that you slow down and want to slow down. I think it's I think it's important. It's hard to find a balance between all those things, but I think health and wellness takes on a new perspective. I know in my particular case, I'm actually quite a different person how I was to how I was 10 years ago, and part of that is the result of one of the comorbidities I mentioned, which is my health, my heart condition. I had an aortic valve replaced, which wasn't all that much fun. But after that, I went into something called cardiac rehab. So there's that word again, rehab. And that actually kind of changed things around, because part of that program was to do with exercise, and part of it was nutrition and going to a gym regularly and getting into that habit. And I left the rehab program and actually took up exercise. And I listened to my nutritionist person mostly. I have a liking for desserts, so I have an adapted diet from what she actually advised I should be doing. But I have lost weight, so I must be doing something right. But I do think I would love to think that the kind of work we're doing, if it became widespread and acknowledged that there are better outcomes if you watch your nutrition, watch exercise, watch mental health, watch support services, how the support you're getting, the outcomes are going to be better. And I think if the sector has any role in that at all, it's for people who do work in the sector to become proficient in those issues, become proficient in dealing with people who are aging, but still who need to exercise, who still need to eat properly, who may have practical needs that we can help with as a sector. But I don't feel right now that the sector of the ASO sector is well versed in helping people of my age. I really don't. So whether there is a place for them, as I say, is I think still up in for grabs. I think we need to talk about that more. But I do sense that the people in my ASO have not experienced aging, and to be frank, don't know much about it. So I think that has to change as the population gets older. We need to be more expert at rehab, if you like. And there's a role I believe Realize could have a role in improving the efficiency and abilities of those in the sector to understand and respond to the issues of people living with HIV who are old, aged, whatever word you want to settle on.
Thanks, Bob.
All right.
So you've sort of led us towards our next question. And I'll actually start with Leanne. We've talked a lot about how Realize has grown and transformed as an organization in the past 25 years, from HIV and rehabilitation towards optimal health and well-being. But as you mentioned, Bob, that there is still a role for rehabilitation. And so in my mind, optimal health and well-being is sort of more widespread, that takes into account rehabilitation, but everything else that has been mentioned, like social inclusion and community. So Leanne, where do you see Realize going in the future? And do you have any words of wisdom as we move forward?
That's a big question.
It really is.
And I am certainly not the expert in this, and I want to make sure that caveat's there. I'm thrilled to hear that Kate is still doing the work in HIV and aging, and that Bob's so involved in that, and I just am honored to be on this panel with you, Bob. I thank you for that, for what you shared. I was thinking about optimal health and well-being, and the importance of connection. And as we age, but as we are living with an illness and wellness that's attached to it, and finding our way, and we sometimes find it in different ways. And I think, just Bob being able to share what he did around, he found the gym. And he found, and that's not an ASO. That's a different, there's different communities throughout, and that opportunity, those opportunities around that, and to share that wisdom and to not lose that, and how we kind of capture that, and some of the things that you talked about, Bob, around 50% of those living with HIV are over the age of 55. How do we not lose the wisdom that's being gathered as the work has been continued with that, and coupled with the continued work around HIV? I think there's learnings from the HIV response and wellness that's associated with it, that can be so helpful in some of the emerging things that I'm experiencing here on the West Coast, and I think others are. And I mean, we have internationally around COVID, and in the long COVID, and but there's a ripple effect of that, and that's the people that have been working in that, and there's in the healthcare settings, and with anyone that's been providing services around that, people are tired, and that tiredness is leading to burnout, and so we're seeing the hospital, at least out here, we're seeing hospitals close because they don't have enough staff, so they're closing on weekends and those kind of things, so not able to provide services. So I think when we look at long COVID, that looking at some of those pieces, and then always, which has been one of the things that Realize Quigger and now Realize has been living with, is how broad do you go, and because you don't want to lose the focus of where we started, and what our primary purpose, if you will, or how that's looked, but we're also seeing some impacts of those who are living with the impacts of fentanyl overdose and overdoses, and we see that here all the time, and so they're living with these with what is turning out to be episodic disabilities associated with the results and the impacts of those overdoses, and so those who survive them, and so that's a real and immediate need that we're seeing here. I don't know if Realize even has a part in that. I don't know that. I'm only saying what I'm seeing and what I'm experiencing here on the West Coast.
Thanks, Leanne. Lots to think about there. Bob, how about you? You've talked a little bit about the future. Do you have any words of wisdom as Realize moves forward?
Words of wisdom. I'll give it a go. Again, well, I'll repeat one of the themes of what we've been talking about today, and that's all about change and adapting to change. And I think we have to, it's hard to predict where Realize will be, say, in 10 years. But I was thinking while we were talking, how even the concept of rehab and what it means to realize has changed. I know in my initial introduction to rehab, we're probably talking, or my reaction to the work that Realize was doing around rehab was probably based on a misunderstanding, in that I thought rehab, it sounded a lot like you folks were trying to get me to go back to work. And as somebody on long-term disability who'd already had some interaction with the rehab person from my insurance company, who definitely wanted me to go back to work, I thought that's what we were talking about. Now, and then as I got into it, I sort of understood that rehab is much more about reinventing people into a better place. I don't know whether that's your definition, but that's kind of how I think about it, leading or helping people to a better place. I think as we realize that the life expectancy now, I don't know whether everybody realizes that the life expectancy of a male at birth anyway is 82. And that's so and for female, I believe it's closer to 84. But if we don't have any kind of intervention in whether it's from us or social agencies, their final years are not going to be very healthy or fun or any of those things. They're going to be difficult. I think we can help with that. I think. Again, there are not too many people right now beating the health and wellness drum in the sector. There are not too many people beating the aging drum in the sector. I one time, I don't know whether it's true now, Kate was pretty well the only person. I think there's isolated people working on the aging. Have an aging portfolio, but considering where we're going, that's not nearly enough of a response. So I think Realize can be the cheerleader for healthier living. I think if we still have 20% of us are smoking, where's the health and well-being there? Where's the health and wellness of a demographic which is hooked on smoking? And we all know what that will likely lead to. They probably won't be living to 82. But it's an example of where we have not really got our feet wet so far, or really nutrition or exercise. Well, I won't. That's a bit unfair because we're seeing the HIV in motion. People are starting to research ways that we can introduce exercise into the population of people living with HIV, and that's great. But the fact that they're just at the research phase with 30 people speaks volumes. I mean, by this we've known for a long time that people with HIV are aging. We know that exercise is an intervention which works. We hardly even need research into that. But really, in terms of our involvement in making progress on that, we're really at baby steps. And I think we have to pick up the pace a little bit. Baby steps are not going to get us where we want to be. So I really think that, again, because they're realized as taken on themselves a role in the health and well-being field, they can really make a difference. I really think they can. So I'm very optimistic about the future of Realize, and I actually love to be, even though I'm retired, I would actually love to be continue to be part of those discussions.
Thanks, Bob. That's a positive note to end the webinar on. And we have your email address. They'll be reaching out to you again, I'm sure.
All right.
So thank you, both of you, Leanne and Bob, for being here and sharing your connection with Realize and your expertise in the work that you've both done and experienced. Before we end off officially, I would like to let you know that Kate Merzin will be hosting the next webinar on HIV and aging, and it will be in the last week of October. And we're also hosting a symposium and policy dialogue on HIV and aging on October 18th, 19th, and 20th. And on the 20th, I think it's going to be it's going to be all fascinating. We're going to be having topics on exercise and loneliness, comorbidities, polypharmacy, sex and pleasure, and frailty. So a bunch of conversations. And the last day is a policy dialogue where we'll be trying to bring together these sort of disparate worlds. I think, Bob, you've touched on this as well, the disparate worlds of aging and HIV. And so we're hoping to bring both those worlds together. Kate has added a link to the symposium and the policy dialogue in the chat. And so we'd love for you all to join us. They're all free and virtual. or in Calgary in person. So yeah, that's the end of it, and I hope to see you at future events, and realize we'll always be adapting and changing to the needs of people living with HIV. So hopefully we'll still be here for another 25 years at least. Thank you.
Okay, thank you.
Thank you.